Hi everyone, thanks for listening to my presentations. Today I'll be talking about goiter, and this will form part 6 of 7. If you haven't listened to parts 1, 2, 3, 4, and 5, please kindly do. Okay, let's go. Goiter simply means an abnormal growth of the thyroid gland. And if you have followed this series, part 1 has given me the privilege to give a brief anatomy of the thyroid gland. And there you would have discovered that the thyroid gland is anterior to the trachea and esophagus. So it's located at anterior part of the neck. So there'll be enlargement of the anterior neck, and sometimes it's not visible, okay? Because most goiter are diagnosed or picked accidentally while carrying out investigation on something else. I mean, the patient will present with another disease entirely. Okay, so abnormal growth of the thyroid gland could be diffuse or nodular. But have a plain mind while approaching anyone with goiter, because we should not erroneously feel that, oh, see, the thyroid gland is enlarged, though that must be hyperthyroidism. Or, no, it should be hypothyroidism. You know what? You may be right or wrong, because it can be causing increased thyroid hormone production, that is hyperthyroidism, or decreased production of the same, which is hypothyroidism, or you carry out the thyroid function test and everything is within normal range, euthyroid state. So, can't judge from afar. Anatomically, thyroid gland is about 4 to 5 by 1 to 2 and 1 to 2 centimeter in size and diameter. By volume, 7 to 10 mils, and by weight, 10 to 20 grams, and slightly higher in men. The growth, it increases with age. In other words, we don't expect goiter in children, right? And it increases as our body mass index increases. So it increases with age, increases with weight. It decreases with increasing iodine intake. So if you are living in a region with enough iodine in the diet, it's not likely you have goiter. In other words, it increases with decreased iodine intake. So in endemic regions with less iodine in the diet or in the soil or in the food that they grow, then the prevalency of goiter will be high. Thyroid usually grows outward. So enlarged goiter may not compress the trachea, may not compress the esophagus or the blood vessels or nerves. And I think I've explained that right. Usually it grows outward. But if the enlargement, if the thyroid gland has grown so massively, if the goiter is so big, it can cause compression. Okay, still on growth. There is likelihood of bilateral lobar enlargement, and that may cause compression. It is possible to have thoracic inlet obstruction with the type of goiter that it is retrosternal. Okay, retrosternal goiters will have thoracic inlet obstruction, and that will lead to a lot of physical presentations. What could cause this? Mostly iodine deficiency. Multinodular goiter will likely occur in older adults. And chronic autoimmune diseases like Hashimoto's could lead to this. Grave disease, and of course tumor of the thyroid gland, and of course inflammatory process, that is just like in autoimmune, right, will all probably cause goiter, but mostly iodine deficiency is enough to lead to goiter. Still on causes, infiltrative diseases like sarcoidosis, goitrogens. Goitrogens hinder thyroid hormones production by hindering iodine uptake in the thyroid gland. The released thyroid-stimulating hormone will promote the growth of thyroid tissue. Okay? Remember, the goitrogens already they've hindered the thyroid hormones production, but TSH is released because there's low level of thyroid hormones. So the TSH is working on the thyroid gland, but the goitrogens are not allowing the hormones to be released. And then what will TSH achieve? The TSH will achieve growth of the thyroid tissue itself. Iodine, if in excess, can cause goiter, just as iodine deficiency will also do. Lithium carbonate or amiodarone can cause goiter. Food served like cassava or millet can cause goiter. Thyroid cyst or genetic constitution. Pathophysiology. When there is iodine deficiency or chronic Hashimoto's thyroiditis with increased thyroid stimulating hormone, then we're in trouble. Predominantly, thyroid stimulating hormone is responsible for goiter production. Several growth factors with thyroid stimulating hormone inclusive can act on the thyroid follicular cells with different growth potentials. Still on pathophysiology, some nodules will later become autonomous due to mutation in thyroid stimulating hormone receptor or G proteins. For example, in older patients, they will have larger volume, and the longer the goiter, the larger the size, because autonomy, coinciding, all right? The larger the size, the lower the serum thyroid stimulating hormone, because it is less dependent on thyroid stimulating hormone. Is that not what autonomous is all about? Now, doing things on your own, independent of the other, right? So, TSH is responsible for quite the larger number of goiters, but in certain situations, autonomous production due to mutation in TSH receptor or G proteins could set. What are the possible clinical features? Could be asymptomatic. As a matter of fact, that's the way it is in many people, right? Incidentally found on examination, and they grow slowly over a long period of time, usually decades. Still on clinical features, we might be dealing with hypothyroidism if the cause is due to Hashimoto thyroiditis or severe iodine deficiency. And with that, we'll be dealing with all signs and symptoms of hypothyroidism, which I'll not go into right now because the next series after these parts 1 to 7 will be all about hypothyroidism. So you can check my channel in the next 2 weeks about all signs and symptoms, including treatment of hypothyroidism. We can be dealing with hyperthyroidism. Remember I said at the beginning that just have a plain mind when you are approaching anyone with goiter, because you might have hypothyroidism, hyperthyroidism, or euthyroid state. So if we come across hyperthyroidism, it might be that we are dealing with multinodular autonomous goiter, or there's Graves' disease as the cause. And of course, all the signs and symptoms of hyperthyroidism, which I will not go into right now because there will be a separate presentation on Graves' disease, on thyrotoxicosis, thyroid storm, hyperthyroidism, and every stuff involved there. Obstructive symptoms and pain. In a very large goiter, particularly retrosternal goiter, we are likely going to be dealing with exertional dyspnea and positional or nocturnal dyspnea. It might present with stridor, wheezing, choking sensation, cough, snoring, and apnea. So, like I said, so many people will have the diagnosis for the first time because they presented with something else, and in the course of physical examination and radiological investigation of the symptoms on account of which they presented, the diagnosis of goiter could be made. So like CT scan is done, and somebody having dyspnea or wheezing or stridor or apnea, and then retrosternal goiter is picked. It could also be due to compression. When the symptoms are secondary to compression, we might be dealing with dysphagia, that is difficulty in swallowing. Hoarseness of voice, particularly if recurrent laryngeal nerve is compressed. Phrenic nerve paralysis affecting the diaphragm. Horner syndrome, that is going to be due to cervical sympathetic chain with meiosis, ptosis, and anhydrosis. That is Horner syndrome. Cerebrovascular stent syndrome is possible when thrombosis has occurred from jugular vein compression. And of course, we might be battling with superior vena cava syndrome. How do we make the diagnosis here? History and physical examination, mostly incidental on radiological investigation on account of different presentation entirely, and it could be diffuse or nodular. Okay, here is a patient with goiter, and you want to carry out the thyroid function test. The value of the TSH is before you, and it is low. Then you are thinking, oh, do I have hyperthyroidism? Measure your T4 and T3. If the value comes back that you are dealing with normal T4 and T3, and TSH is still low, then you are dealing with subclinical hyperthyroidism. But if the value of thyroid function test returns and your T3 and T4 are elevated in the face of low TSH, the diagnosis is different. That is overt hyperthyroidism. And if the goiter is obvious, you are dealing with toxic goiter. Still on diagnosis. Overt hyperthyroidism or toxic goiter, you are not sure, then rule out Graves' disease or autonomous multinodular goiter. You can do this by using thyroid uptake and scan. You can have thyroid ultrasound with vascularity assessment. You can measure your thyroid stimulating hormone receptor antibodies. But if your thyroid stimulating hormone is within normal range, then measure your thyroid peroxidase antibodies. And why that? We want to rule out Graves' disease or Hashimoto's thyroiditis. If thyroid peroxidase antibody is negative, do ultrasound. If ultrasound reveals no nodules, then your diagnosis is diffuse goiter or seronegative Hashimoto's or biosynthetic defect. However, if you have a different result, giving you that the ultrasound reveals nodules, the diagnosis is different. You are dealing with multinodular goiter. If there are no symptoms, do nothing. You can monitor only. But for cosmetic reasons, particularly in females, they may want cosmetic surgery to get it out. Okay? But if there are symptoms, or you are suspicious that there will be symptoms, then do what is needful. Fine needle aspiration cytology. But if thyroid peroxidase antibody is positive, your diagnosis is Hashimoto's thyroiditis. You can have ultrasound and fine needle aspiration cytology done. If there are symptoms, please treat appropriately. If we are dealing with a high thyroid stimulating hormone, please measure your free T4. The normal T4 with high TSH will be pointing to subclinical hypothyroidism. But if you have high TSH and low T4, you are dealing with overt hypothyroidism. Then go a step further. Measure your thyroid peroxidase antibodies. If it is positive, make your diagnosis Hashimoto's thyroiditis. If you are dealing with a very high thyroid stimulating hormone and you carry out thyroid peroxidase antibodies level and the value is negative, but the TSH is high, then you might be dealing with Hashimoto's thyroiditis. It might be biosynthetic defects in thyroid hormone synthesis, or you might be dealing with iodine utilization, or you are having infiltrative disorder of the thyroid gland at hand. In that case, then you do ultrasound. Okay, if you are still dealing with very high thyroid stimulating hormone level, if you are not suspicious of any other features, just monitor. But if you are suspicious, do fine needle aspiration cytology. Finally, check for features of compression. You can rewind this very presentation to get the features if you are confused. Okay, you can do CT scan. And of course, radio contrast agents should be administered with caution. And somebody will ask me, why that? Okay, it's because of the probability or possibility of overt hyperthyroidism when you administer your radio contrast agent. Okay, or in someone with low TSH, high T4 and T3, that is hypothyroidism, you can exacerbate that. And of course, it will be wise to take a thorough history and a thorough physical examination. What are the possible differential diagnoses? Might be dealing with lymphoma, might be dealing with teratoma or thymoma. Bronchogenic carcinoma or cyst will be possible. Pericardial cyst, substernal or retrosternal goiter, ganglioneuromas in the posterior mediastinum, and of course metastatic lesions. And with that, I've come to the end of part 6 of 7. The next is going to be on LEMS. And someone may be asking me, what is LEMS? It's not lemon, it's not lemonade. It is Lambert-Eaton myasthenic syndrome. You've heard about that before, right? Okay, watch out. That presentation will follow this very one. Okay, thanks for listening to all my presentations. Please remember to share and subscribe. I appreciate it.